Okay, so one more to come in. What is here?
One more from our group, Doctor.
Okay. Isha Ma'in siapa?
Ada group.
Ada group, okay. Dah,
Dah.
Okay. Alright. Okay, let's start with Assalamualaikum warahmatullahi wabarakatuh. Let's start with Ummul Kitab Al-Fatihah. Okay, so I'll give to siapa itu, I can't remember the name now.
Hey, Madia Safwana.
Madian. So I give two slides and there's two slides. So today we're going to do a session 3 punya slide and so we
Yes.
two cases, and then tomorrow we're going to do the session 4 slides, which is going to be another two cases. So I've done this kind of session with other groups as well. So I don't know whether you guys already joined the other groups discussion. So it's a problem-based learning. So we give you the case, but you need to kind of like doing the case like you're doing a long case kind of presentation. So one of you will lead the discussions, and then the rest of you can chip in, or the person leading the case can ask other people's question for the sake of discussion to make it a long case discussion. And obviously at the end of the case, I will summarize and I'll give you a few more kind of like point to complete the case. But obviously the problem-based learning is about how you're going to elicit and also extract more information from the case to basically come to a differential diagnosis and eventually the provisional diagnosis. Okay, so who's going to start first?
Me, Doctor.
The floor is yours.
Assalamualaikum. My name is Anis and I will lead the first cases first. So for the first case scenario for the session 3, Yuan, a 2-year-old boy, is referred to pediatric day unit by his GP due to fever, cough, blocked runny nose, and sticky eye for 6 days. His GP prescribed amoxicillin 2 days ago for otitis media, and that evening, he started to develop a rash around his ears and hairline. His parents stopped giving the antibiotics, but the rash continued to spread all over most of his body. And the parent report that he very miserable and lethargic for the last 5 days. He thought the rash may be an allergic reaction to the amoxicillin. And the child attends nursery, but his parents are not aware any other children who have been unwell. His parents are well, and he has an older brother who has autism. So, any word that you do not understand from this case scenario? Okay, no. So for this child, what do you think the causes of his sickness? For this short history. So I will proceed. So for me, I think maybe one of the causes, because this child have fever, maybe what is the infectious causes, which is one of them is the viral. So my provisional for this one is measles. Why? Okay, for started is because the the prodromal symptom for measles, this is the 3C, and this child have it, which is the cough, conjunctivitis, and also coryza. uh, okay. This child also have fever, and so the incubation the incubation. What should I? So okay, so the rashes started. The GP said that the parents said that the rashes started at the day 3 after the fever. And the rash, usually the rash in measles consistently appear after day 3 or day 4. The child appear to be the rashes from measles also started from the head, which is usually from the hairline, and spread to the over all his body. And the child also appear lethargic and miserable, which is one of the symptoms for the measles. And also, the GP said that the GP prescribed amoxicillin for 2 days ago due to the otitis media. And for otitis media is one of the complications for the measles. And okay, uh, that's all for my provisionals. Other causes for this case. Najla?
Okay. So I think maybe patient might have Roselia infantum because patient presented with fever and also upper respiratory symptoms such as apa, cough, runny nose, and cough and runny nose. So in Roselia infantum, actually usually the rash appeared after patient had the fever. After fever, patient had the rash. Yes, and then I think why I think this patient have Roselia infantum because one of the risk factor is that the patient attend to the nursery. So when patient goes to the nursery, it's they have the high risk. They are exposed to many viruses. And then for otitis media, actually it can be same as it can be one of the complication because when the patient be infected with the upper respiratory tract infection, so the virus or bacteria can impact the eustachian tube in the middle ear. So what happen is that it can cause imbalance of the pressure inside the middle ear. So it can furthermore invite or bacteria or virus inside at the middle ears. So it can cause inflammation and so on. I think that's one of the causes.
Okay. So, talk about the Rosella infantum. What about other causes?
Maybe he can have infectious mononucleosis, even though it doesn't meet the criteria like the classical triad of infection mononucleosis like lymphadenopathy, pharyngitis, or fever. However, because usually infection mononucleosis not shown all the symptom, it can be present only by fever only. So I think it can be infection mononucleosis, and moreover, there is like after prescription of the amoxicillin, it just develop a rash, which also a characteristic of an infectious mononucleosis, which we can not give the amoxicillin to the infection mononucleosis patient because it can develop rash afterwards.
Okay, talk about the amoxicillin rash. Can someone told me more about the amoxicillin rash? Anyone? Okay. So for what I read about the rashes, that for the amoxicillin rash, the rash usually appear between 3 or 10 days after the starting of the antibiotic. But for amoxicillin rash, it can any time during the course of the child antibiotic, and these rashes usually appear as maculopapular rash, and it's also very serious rash. Second question. Okay. So
And I
yes.
Ni? Okay. I would like to add on about the amoxicillin rash. So actually amoxicillin rash, there are two types. It's hive or maculopapular rash. So hive usually caused by the allergy. So the type of rash usually it's a little bit raised and itchy, and there will be red or red bump in the skin. But for maculopapular rash, usually it's appeared about 3 to 10 days, as you said, and the characteristic a little bit more flat and red patch on the skin. Maybe we have to clarify to the
Whether it is allergy or
yes.
amoxicillin rash. So we can put the one of the diagnosis as allergic to penicillin, different from amoxicillin rash.
I think we can.
I also want to add. Can you hear me? Okay. For the amoxicillin rash, there's another symptom apart from rash, which is more common is diarrhea and stomach ache. So we can further ask the patient if he has any diarrhea or stomach ache apart from the rash in order to confirm our diagnosis. That's all.
I also want to add, it's more to generally, a more general diagnosis, which is atopic dermatitis. As the name say, that it can be due to numerous triggers. It can be environment, it can be allergic reaction, and then hence I want to ask during the history taking any family with the same symptom as his, or any allergic to food or drug, or even he is allergic to certain substance. For example, soap or detergent. That's it. That's what I want to add. Another diagnosis is atopic dermatitis.
I want to
Baik.
add another DX. That is rubella. The other symptom will be, we need to ask for the fever, whether it is a low grade or high grade, and then because the patient have malaise for a few days before the rashes come, and also we need to ask for the headache, mild pharyngitis, and also how the rashes started from the beginning, because in rubella the rashes usually started from the face and spread to the whole body. That's all.
Okay. So, Wana, anything you wanna
I think we should rule out any autoimmune disease also, like Hinosolim purpura, because among the symptoms like there preceded URTI, and then there is other symptom like fever also, other like arthralgia or abdominal pain, but in the patient we don't know, and then there is rash. I think that's all. And we should know the family history of any autoimmune disease also.
um
I think that's all.
okay. Raja?
For now, no addition information.
Raja?
Sorry to interrupt. I think we should also consider dengue, because dengue is endemic in our country. So patient with fever and comes with rashes, malaise. So I think I would like to exclude dengue as well, and I would like to ask more about the dengue prone area and other symptoms of dengue.
Okay. So apart from the differences, so what more we need according to our many differences, measles, infection mononucleosis, atopic dermatitis, rubella, HSV, and also dengue. What further question that we want to ask the guardian and the patients, the guardian, to exclude all of these differences?
So basically, I just let me interrupt here, because it looks like that we kind of like melirik-lirik in terms of our differential diagnosis here. Sorry, can you hear me, guys?
Yes.
Okay. So if this child come into ED department, okay, let's say this child come into ED department, not to clinics or pediatric ward, come to ED department. So you got a 2-year-old child coming with history of 6 days of fever, plus they had a blocked nose, plus they had a cough, plus they had the sticky eyes. Okay. So what will be the most important question you want to ask the mother or the father first? If somebody got rash, what is the most important question? Okay, the most important question you want to ask, because this important question is a life-saving question. So
Immunization.
nope.
Any allergic history?
No. So it's a life-saving question about the rash.
Is it painful or itchiness the rash?
No.
How long has the rash come?
Okay, so how long? I said the history says the fever, the cough, the blocked nose, the sticky eyes for 6 days, and then there's a rash coming up. So what would be the most important? I would say the 2 most important questions you want to ask the parents. If somebody got rash, there's 2 most important questions you want to ask.
Sepsis, doctor?
Yeah, sepsis. So what kind of sepsis question you want to ask about the rash?
Is there any vomiting history?
No, about the rash itself. Okay, semua orang tengah Semua orang dah makan breakfast ni? Looks like you guys slowing down a bit here. Okay, the most important question you want to ask is, does the rash blanching or not blanching? Okay, those are the most important question, because if the rash is non-blanching, then it could be whether it's a purpuric rash or petechiae rash. Sebabnya kalau muka papula ni, muka papula normally it's a viral rash, so when you press on it, it will blanch away. Kalau petechiae or purpuric rash, which could be meningococcal septicemia ataupun meningitis ataupun a very severe sepsis, then when you press on the rash, it won't blanch away. So in that particular case, you will need urgent antibiotics going. You want to make sure the blood pressure is stabilized. You want to make sure the heart rate is normal. Kalau the heart rate is very tachycardic, then this child, and also the BP dia hypertensive, this child probably needs fluid boluses and probably needs going to PICU for intensive care treatment. So that's one question about the rash. Okay, another question about the rash. The most important question that is life-saving question.
Type of the rash.
About the rash.
When it started?
It is important, but not it is significant, but not the priority. The priority one when talking about rash.
Distribution. Amount of the rash.
Well, it is important, but not the priority. It should be in your history of presenting complaint or history of HOPI, but it's not really things that is important if the child presented to ED.
Present of pruritus or bleeding?
No, that's not really. Not really. Okay, so if any rash coming in, so first thing you want to know whether it's a sepsis. The second thing is, you want to know whether this rash is due to anaphylactic shock. Okay, so the question you want to ask is, does the child has any breathing difficulties? Okay, kalau the child ada breathing susah nak nafas ataupun ada stridor and so on, then this child will need urgent IM injection of adrenaline. So IM adrenaline. So those are the two questions. So okay, let's go back to the history of presenting complaints. So this is a child, a 2-year-old child, 6 days history of fever. So I want to stress again, 6 days history of fever. I stress again, 6 days history of fever. Okay, cough, runny nose, blocked nose, and also sticky eyes. Okay, so what can you think of conditions that give you prolonged fever?
Kawasaki.
So Kawasaki, isn't it? So none of you talk about Kawasaki in your differential diagnosis.
Because it put the sticky eyes, doctor, so maybe purulent conjunctivitis.
Well, the sticky eyes is a sticky eyes. Okay, but 6 days history. So you've not completed your question yet, because you've not asked about in terms of any swelling of the joint, swelling of the fingers, peeling of the skin. So you've not asked those questions yet. So you don't know whether this is Kawasaki or not. So you should say you should further ask question about Kawasaki. So the fever did more than 5 days. So so you want to know the rash, where is the distribution of the rash, and also you want to know sticky eyes can be sticky eyes, but the sticky eyes does not mean that the child has a purulent conjunctivitis. It's just a sticky eye. So you need to ask further question. Does the child has sticky kita tanya ni lah, mata berair, ataupun mata dia ada kuan nanah ke apa, and so on. So those are the further question you want to ask. And obviously, you also want to ask, is there any swelling of the neck as well? Mak dia perasan tak ada swelling around the neck to suggest cervical lymphadenopathy? Okay.
Okay.
Then if not ask about orang kata strawberry tongue ke ataupun mucosal kind of bleeding ke ataupun lips peeling of the lips, skin of the lips. So those are the question about Kawasaki you want to further question. The most important thing with this history was the child has been miserable and lethargic. So miserables, so Kawasaki can give you the miserable looking, maknanya very cranky, very orang kata merengek sepanjang masa. Merengek tu not that significant, dia lebih kepada very cranky, so cranky. Maybe doesn't like to be touched, doesn't like to be doesn't want to play and so on. Okay, miserables also can be a sign of maknanya kalau ada fever, ada rash, then and also miserables, sometimes measles also can give you this picture as well. Miserables is almost equivalent to measles, especially those yang ada rash. And then the type of rash that measles come with, depending distribution is starting from the behind the ears to the face down to the body. So those are the progress of rash for measles. So the question you want to ask the parents is, dia punya rash dia start macam mana? Start dekat mana? Kalau dia start dekat bawah, mana badan dulu baru naik ke muka, so it's probably unlikely to be measles. Measles tend to be behind the ears, to the face, and then down to the body. So the progression of rash is very important to ask as well. And then you can ask for the question macam seek contact lah. You can ask about question about disorder intake and so on. And then you can ask about kita panggil family history and so on. But in the history also, it says that the brother has autism. Okay. Why is important to know this? Because sometimes parents thought that MMR vaccinations cause measles, because a few years ago, like 20 years, 30 years ago, there's a paper been published by a physician that shows association between MMR vaccination dengan autism. So maybe that these parents believe in that paper. So probably you want to know further question in terms of vaccination history in this child. Does the child been vaccinated for MMR? Okay. I just want to tell you here that the journal that been published regarding the MMR association with autism is a false publication. Somebody falsified the data, somebody falsified the result, and then produce that paper for the sake of their own conflict of interest. So that paper is not really well written paper because so many data has been falsified. Okay, so we want to know whether there is an element of active vaxxers in this case. So that's why they put the brothers has autism because just want to test you. Whether you will ask this question about vaccinations. Okay, so in terms of your history, in terms of your differential diagnosis, you should put Kawasaki, measles, Kawasaki. You can put like rubella ke, EBV ke, what else? I don't know. Infectious mononucleosis. Well, EBV sama macam infectious mononucleosis lebih kurang. I don't know what else. Apa lagi? Osseola infantum. It is nothing much, which is just a self-limiting. None of you come up with scarlet fever. So any of you think about scarlet fever? So with the rash as well, you also want to know what's the rash? Does it feel like sandpapery rash? Bila mak dia pegang ataupun rasa rash tu, rasa macam pasir tak dia punya permukaan ni kan. Those are the questions you want to ask, and obviously with the conjunctivitis, with the whether if there's any history of mucosal changes like strawberry tongue and so on. Okay. In the history also, you can always come up with a possible influenza infection as well, because influenza also can cause fever, prolonged fever, high grade fever, cough, runny nose, and sticky eyes, ataupun conjunctivitis. Okay, cumanya influenza does not really cause a rash lah. So that's the question. So sometimes this child might have influenza and also might have penicillin allergy, and because you give amoxicillin, which is penicillin based, and then this penicillin, if the child got allergic to penicillin, then the child can have rash as well. But obviously, allergic rash tend to come with allergic to antibiotics tend to come with rash and also a possible stomach ache and also diarrhea as well. Okay. And we are in the COVID outbreak, so you want to know in terms of travel history as well. So has the child been traveling somewhere else? Has the child been outside the countries? Because COVID can cause fever, cough, blocked nose, sticky eyes, probably not really. Rash, maybe. Okay, because I don't know whether you know a term that we use nowadays for multi-system inflammatory involvement in COVID patient, especially in children. Dia macam Kawasaki, but not Kawasaki. Nowadays pediatricians tend to use the wording the term as Coronasaki, which means that the patient has COVID positive results, at the same time showing symptoms and signs of Kawasaki. Means that they might have tachycardia, low blood pressures, cardiac complication that also has peripherals, limb swelling, rash, and so on. So nowadays there is association between COVID-19 and also Kawasaki as well. So this is all new things that we need to basically need to elicit from the histories. Okay. Any other differential diagnosis you want to come up with? Obviously, Dr. Syed tend to say if you see a case, you need to think about 10 different differential diagnoses, and so from the 10 differential diagnoses, you will come up with more questions to ask parents to elicit the diagnosis. Okay. Anything else you want to ask? Anis? Okay, you can ask your colleague anything else.
Doctor, can we add varicella zoster? Chickenpox.
It's probably unlikely, kan? Sebab varicella zoster tend to be vesicles, kan?
Kalau yang parvovirus tu, yang slapstick disease.
Slapstick disease is slapstick disease. So it tend to be it's still possible because at the moment we don't really see the rash. It's just a history, and but the thing is the symptom of parvovirus ke slapstick disease ke, if you ask about other kind of rashes pun, normally you can't go wrong from cough, fever, runny nose, sticky eyes, and so on. Kalau macam slapstick, it tend to be both cheeks kind of like redness, and but in this case, it says that it stated that the rash started around the ears, spread to kind of like and then the rash continued to spread throughout the body. So this is a very pathognomonic for measles rash. Okay, and plus it says that the child is miserable and lethargic. Kalau macam EBV pun ataupun macam EBV punya infection ataupun infectious mononucleosis, they tend to be lethargic, not really miserable. Even parvovirus ke slapstick ke Rosella infanta pun, it tend to be just lethargic, not kind of miserables. Okay, the one that normally miserables is Kawasaki and also measles. They tend to be miserables. The reason that measles tend to be miserables was because there is a bit, kita panggil apa, meningeal irritation with the infection. Okay, and except kalau macam septicemia, they tend to be lethargic and probably confused ataupun reduce consciousness because of the low BP and the tachycardia. So they tend to be quite moribund ataupun limp. Unless you're talking about early meningitis punya symptom. Kalau early meningitis punya symptom, they tend to be very miserable because of the Kernig sign. So because of the painful in the neck and also meningeal irritation, they tend to be miserable due to pain from the meningitis infection. Okay, so miserable and lethargic is quite important to know here, because it will give you, you can list down narrow down your differentials in this case. Okay, so that's the HOPI. So in terms of past medical history, it's probably not significant at all. Obviously you need to ask the question. You also want to know the family history, the social history, going to the nursery or not, traveling histories. You also want to know the vaccination history as well, because that's quite important nowadays with the COVID punya issues. Any other question you want to ask, or any other point you want to add on?
And Doctor, is it possible for HFMD?
Okay, so you want to ask your colleague about that? Is it possible?
Yes, I want to ask my colleague.
I think it is possible, however, least likely because of the distribution started from the neck
Hit.
in this.
Okay, because the history doesn't mention about rash on the hands,
Hand, mouth.
on the feet, the mouth. So it's probably most likely that we are not talking about HFMD.
Yes.
Okay, so I've put down the examination findings in the chat box there. So from there, what can you make of can you further narrow down your differentials? So obviously the child has high grade fever, and the heart rate is tachycardic.
Tachy.
Respiratory is not that
No.
not that fast. I would say borderline. Oxygen is okay. Miserable and lethargic. There is macular papular erythematous rash, which is coalescing over his face, neck, and torso. The heart rate are normal. The TRT is 2 seconds, which is not too bad. No respiratory distress. He is coughing. Lost transmitted upper airway noises in the chest. Abdomen is normal. Dia punya nose dia memang orang kata berai hidung teruk lah. Semua dia quite bad. And also there is a purulent discharge from the right ear. And there's the punya pharynx dia red. That's dia ada exudative
conjunctivitis.
Okay. So with this information, okay, can you further narrow down your differential?
It is most likely Kawasaki due to there is a high grade fever with widespread maculopapular rash, which is erythematous, and there is also uh, redness at the pharynx and also with evidence of exudative conjunctivitis. This is most likely showing that the symptom of the Kawasaki disease.
Okay, so does everyone agree with Aiman? We are a democratic country. You can agree to, you can disagree. So it's up to you. So so there is 13 of you. All of you agree with Aiman?
I
Yeah,
do
I agree with him.
However,
Siapa yang agree ni?
Wajiha and Faiz.
Yeah, Faiz. The rest of them? The rest of you disagree?
but I think doctor, it is, I agree with Raja. However, I think personally it is more pointed toward measles.
You agree with Raja tapi you disagree, so you disagree lah. You disagree.
Can you tell us why more pointed towards measles?
Sorry.
In
Dia
my
marah.
in my humble opinion, I think it is
Very political punya statements.
because first of the high grade fever, and then patient have maculopapular rash, which is coalescing.
Okay.
So it is more likely to be measles, and then the exudative conjunctivitis.
So, okay, so anyone agree or anyone disagree? Anyone want to argue? Anyone want to argue? Probably Wajah want to explain further. What do you mean by coalescing?
Dia macam bercantum-cantum rash dia.
Okay, alright. So the rest of you, Pak Ais, Suhaila, Afifah.
I think also measles.
You think measles, eh? So because feminists so apa orang kata apa, sisterhood come together kan. Sorry brotherhood kalah. So not many brothers here, all sisters. Even Ishman tak nak support Faiz.
But to confirm for measles, kalau betul-betul measles lah, mesti ada complete spot kan.
Si.
Tapi complete spot boleh hilang kan lepas rest keluar.
And I know why you suggest Kawasaki disease.
Raja.
Yes.
Suhaila ask more about the why you point towards the Kawasaki disease.
Tadi dah cakap dah.
First. Ask again.
High grade fever, maculopapular rash, with pharynx redness, with evidence of conjunctivitis, exudative conjunctivitis.
Tapi Kawasaki dan suppurative conjunctivitis.
Yeah.
Itu exudative conjunctivitis.
Tak sure jap. Check.
Is there a difference between exudative and non-purulent?
Exudative tu
Berdanah.
Purulent tu exudative.
Okay, so exudative is the same as purulent. Watery conjunctivitis ataupun non-purulent tu sama lah. Mana dia tak ada orang kata apa, tak yang senang mata tak bertahi lah kan. Okay. Alright, so nowadays, so now is it measles or is it Kawasaki?
Measles.
Okay. Measles apa Raja, okay. Measles.
Okay, good.
Okay.
How about his otitis media? It doesn't stated in the PE.
Okay, so yeah, what about otitis media?
Otitis media.
Is it the complication of the measles?
I don't know. You guys discuss lah. You guys discuss everything. So what do you think? Is it complication? Or is it two separate pathologies?
It could be, but why does the clinical examination does not include
Apa?
the otitis media? Does it already resolve?
Ada
Ada.
Josh. Ada.
Ada discharge.
So, I put the examination finding dekat dalam chat box. Tak tahu kalau Anis tak baca chat box. Dia cuma baca komen je. Jangan kecam saya. Hashtag.
Okay.
Okay, so back to the question. Is it Kawasaki or is it measles?
Measles.
Measles kot.
Measles. Okay.
Measles.
Right. So now Raja apa orang kata apa? Telah berubah kepada measles. No, apa benda tak tetap lah. Okay, so it's pointed towards measles rather than Kawasaki. The reason for that, one, I would say the distribution of the rash, and then the word coalescing means that it started from the face, from the ears down to the body. So maknanya dia macam coalescing, dia menuju kepada satu benda yang lebih besar. So those are the meaning of coalescing rash. That's one thing. The second thing is we're talking about exudative conjunctivitis. Because of the purulent conjunctivitis, it tend not to dia macam exclude Kawasaki. Cuma in this clinical finding, we didn't put lymphadenopathy, cervical lymphadenopathy, and so on. If we say that there is no cervical lymphadenopathy, we kind of like ruling out Kawasaki, and we've not mentioned about proximal fingers ataupun digital swelling or skin peeling as well. So kalau Kawasaki, we probably dah mention about this already. So now it's going to be measles. So that's why it's very important to know the vaccination histories. Okay. So does this child completed the vaccination punya schedule? With the anti-vaxxers nowadays, so we've seen the raised case of measles, not just in Malaysia, especially in the Borneo and Sabah Sarawak, and then we have plenty more outbreak in Philippines in a few months ago. I think early of this year, a lot more Philippines punya outbreak for measles. I remember Philippines and dengan Sabah tu very near. Okay, dia orang boleh orang kata naik boat ataupun naik tongkang daripada Philippines datang ke Lahad Datu ke and so on. If they got measles with themselves, they just spread the measles to the area very easily. Okay. So this is a question about measles. Okay. Measles. How are you going to investigate for measles?
Oh, okay.
What investigation you want to do?
The clinical diagnosis
Clinical diagnosis.
Clinical diagnosis, but we can also measure the antibody titer.
Okay. So what kind of antibody titer you want to measure?
IgM.
So IgM for? Is it acute or is it chronic punya?
Acute.
Acute.
Okay, so normally if you got IgM positive, then it probably acute punya reaction. Kalau IgG tu, it tend to be mana the infection has happened a long time ago lah. Okay. Okay, now I'm going to share my slide here. So measles basically is a clinical diagnosis. Obviously, kalau nak buat investigation pun, you can do antibody titer, ataupun if you got the swab for viral measles, and you just swab the mouth, the buccal for measles, but normally you don't do anything else for measles anyway. Let me share my slide. So this kind of like my differential diagnosis: Kawasaki, rubella, EBV, rosea like infantum scarlet fever. I put more there as influenza and also COVID because we are in the COVID outbreak at the moment. The typical history of measles is there's a prodrome phase, fever, conjunctivitis, cough, coryzal. Then normally the rash develop later on. Then complete spots will be seen in the buccal mucosa. And if you see a complete spots in the mouth, it's very pathognomonic for measles. So if you see it, you don't need anything else. It's measles. Okay. Cumanya complete spot is so hard to see. Because normally it lasted about 1 to 2 days, and then after that it disappears. So that's why it's so difficult to see complete spots. The rash there is a maculopapular. It tends to start behind the ears, about the hairlines. That's spreading downwards to the body. It's confluence upper body, and sometimes it looks like a blotchy kind of appearance. The rash dia macam nampak blotchy. And most of the time, patient yang ada measles, they look very miserable. So they look very cranky. They are quite merengek selalunya. Okay, and then the complication of measles. So it can be pneumonia. So that's why very important to check for the chest signs. Kalau ada crackles, ada crepitation. Sometimes they can come with shortness of breath. So measles can cause pneumonia. It also can cause suppurative otitis media. So that's why in this case, the otitis media is the complication of measles. In a very rare occasions, measles also can cause corneal ulceration. Mana sometimes with the measles, the cornea can dia macam ada macam scarring as well. And it's part of the measles complication. GI tract complication, macam vomiting and diarrhea, and sometimes it can cause febrile convulsion. The reason that we vaccinate against measles is because that you don't really want them to develop, we call it SSPE, acute sclerosing panencephalitis. SSPE does not really develop acutely. Maknanya it does not really happen immediately once you got the measles. It can happen within months, within years. Sometimes years too. It could be down 20 years down the line. So if you got measles now, 20 years down the line, you might have SSPE later. So it does not really develop acutely. Hence the word subacute sclerosing panencephalitis. However, encephalomyelitis tend to happen acutely. However, both of them, encephalomyelitis and also SSPE, it's a very rare complication for measles. However, if it happens, it's a very very severe kind of form of complication. So kalau macam SSPE ni, if you develop SSPE, you look like you are developing CPs. Sometimes you have seizures, you lose your mobilities. You basically not functioning as a normal person if you develop SSPEs. Ataupun SSPEs, normally you got a normal child, and then once you develop SSPEs, you kind of like having developmental regression. If you walking, if you speaking before, and then by the time you develop SSPE, you tend to be regressing. Maknanya kalau before this you can speak, then you cannot speak. Before this you can walk, jump, running, and so on. Then you can be bed bound, you can be wheelchair bound, and so on. So SSP is quite a severe complication of measles. So that's why we vaccinate against measles nowadays. Okay, so this is just a data from the UK. So MMR, as I mentioned before, there's a publicity of a study linking MMR vaccination and autism. Despite the publication shows there is no signs ataupun the data has been falsified about MMR vaccination with autism, because people believe in this, it caused the public scare. So that's why the uptake of MMR vaccination in the UK around the year 2000 has dropped. Hence, the herd immunity is also dropped as well. So that's why you see the raise of measles cases at that time. And nowadays in Malaysia, the anti-vaxxers, kalau kat UK ni, anti-vaxxers started in 1990s lagi. In Malaysia, macam baru je nak start anti-vaxxers ni. So that's why nowadays in Malaysia you see measles cases a lot because of the anti-vaxxers, meaning that our herd immunity, we lose our herd immunity. So that's why we get the measles cases nowadays. The issue is now not all people sees measles, because measles was almost eradicated years ago, and now it's coming back again. So sometimes people miss seeing measles because they've not seen measles before. It's like you're seeing a polio one. So because polio has been eradicated for a long time before, and then you also see measles coming out. Same as case of you've seen rates of polio cases as well recently in Sabah and also in Philippines as well. So same as measles. So nowadays you can see measles because people don't take measles. Nowadays you see polio because people's not taking vaccination for polio recently. So that's why we lose the herd immunity. Remember, we need to bear in mind that all these viruses, measles viruses, polio virus, they're all in our environment. So it does not go away. Sama macam influenza, even though we have a vaccine for influenza ataupun coronavirus nanti, the virus is still in the environment. It's just that we have this active immunity by taking the vaccination. So we get the active activation of our immunity system. So that's why we develop the herd immunity. But the virus is still in the environment. So that's what happens if you lose the herd immunity. Okay, so measles is becoming more common and common, not just in the UK, but also in the whole global world at the moment because of the reduced vaccination uptake. The measles typical phase there happened before the rash, and then the rash evolve in the specific fashion, mainly coming from the behind the ears, from the hairline, and then spreading downwards to the body. And then if you suspect measles, you just notify. Kalau kat Pahang ni, you notify Jabatan Kesihatan Negeri, and then they will do the contact tracing and so on. And obviously, measles can be complication. They can be horrified as well. Sometimes it can cause morbidity. Sometimes it can also cause death as well. The death from the measles mainly because of the lung complication. Okay, any question about this case?
Doktor, kalau dia dah kena measles, dia perlu vaksin tak lepas tu? Dia dah ada antibody dekat measles tu.
So let's ask your colleague.
Rasanya dah ada kot antibody. Sebab vaksin tu kan macam like from virus itself tu kan.
Okay. Anyone else want to add more?
I think measles infection can produce lifelong antibody, so no need vaccination.
No need vaccination. Anyone else want to add more ataupun disagree?
I agree with Wajihah because I think I read somewhere that it's a lifelong immunity after we got the measles.
Okay, anything else? Semua orang agree kan? So apa? You don't need to vaccinate after you got measles infection.
Yeah.
Okay, so there's no right or wrong answer in this particular case. So you expect that after you got the infection, if you got measles infection, your body will develop the antibody against measles. Okay, so those are one view of for those yang kata tak perlukan vaccination. For those yang kata you need to have another vaccines after the infection because the argument was after 3 months or after 4 months, your immunity system, your IgG will goes down. So what you do is you give another dose of vaccine of MMR after 3 to 4 months to boost the antibodies after that. So those are the argument for having dia macam booster lah. So normally if in our schedule of vaccination, you get 2 MMR vaccination kan, masuk umur 9 months and also 12 months. Okay, so the argument was if you have the measles infection by 2 years, okay, the idea is to get another vaccines maybe after 3 to 4 months after the infection, so that you got the IgG booster after that. So those are the argument of having give one injection MMR vaccination after the measles infection. So but theoretically you already developed immunity against measles once you get the measles infection lah. Macam we develop immunity against chickenpox lah. So you got one chickenpox during childhood, then you develop the lifelong immunity after that lah, unless you develop shingles or itu lain lah. Okay.
Okay.
All right. So who's doing the next case?
Second case.
Nourish mine.
Okay, case 2. Cindy is a 11-year-old girl referred to the pediatric outpatient by her GP. The letter says, "Thank you for seeing this girl who has had her first beat. 3 weeks ago, she was at school when the fire alarm went off unexpectedly. She felt faint and clammy. Friends tried to help her to walk out of the classroom, but after about a minute, she collapsed to the floor and had a brief episode of jerking movement affecting all 4 limbs. There was no incontinence or tongue biting. She regained consciousness within a minute but continued to feel weak for a few hours afterwards. Cindy had a febrile convulsion at 18 months of age, and she has fainted on about 5 occasions, mostly in emotional situations or when it has been hot. She describes herself as an anxious girl and has a sensation of her heart racing every few weeks. She has never been in hospital but has seen her GP for heavy period. There is no family history of epilepsy, but her aunt collapsed and died at the age of 28 in Kelang. She is top of her year at school and hopes to be a doctor or lawyer. So anyone want to ask any question or anything that you don't understand from the scenario?
Semua main TikTok. Orang main TikTok kan. So the tips, Ishman, you need to say the name. Okay. if you ask anyone is not going to help you. But if you mention like Aiman ke Faiz ke, so you put in the honest for them to answer the question. If you say anyone, there's no one named anyone. Okay, so pick a name.
Right, okay. For the complaint is I would like to summarize the complaint. So she just 2 weeks ago felt faint and clammy and collapsed and have jerky movement, so like seizure, and also she regained conscious after minutes and continue to feel weak after that. And also she has also have fainted history 5 occasions, usually due to emotional and hot. And she also has seen GP for heavy fluid. Okay, so Madhya, do you have any diagnosis in your mind? Depression diagnosis?
In my opinion, based on the symptom, it might be related to endocrine problem. For example, like hypothyroidism. Actually, most of the symptoms associated with hypothyroidism symptoms like anxious, and then there is heat intolerance. So there is complaint of palpitation. And I mean the presentation like seizure may be related to arrhythmia maybe, and then there is had problem with menstruation, which is a heavy period. And then regarding the aunt, we should know the exact causes, what caused the death of the aunt. I think that's all.
I want to ask something. What is the significance that we need to know that she is at top of her school?
Maybe she does not have any developmental delay or global developmental delay.
Another one is it's kind of contradict because on the second paragraph, the first paragraph she said that her first fit. However, on the second paragraph, she that febrile convulsion at 18 months. Or is it the difference between fits and convulsion?
So yeah, she has a febrile convulsion at 18 months old. And then mana fit tadi?
Yang first GP cakap yang first paragraph tu. Had first fit.
So that's a GP punya letter, so that doesn't matter.
Oh.
Okay.
Doesn't matter.
So maksudnya that based on history, he has several fits episode dah lah ni.
So basically, looks like from the history she has
several
multiple episodes of fits lah.
So epilepsy ni.
Whatever the letter says, but the GP is just GP. The name general practice is that they are general practice. They're not neurologists. They are not. I would say they are not doctors.
Oh.
Sorry. So GP is just GPs. So they don't really know much in term of epilepsy and so on. So that's okay. Kalau dia kata thank you for seeing this child for her first fit. So that's fine. Okay. But the most important thing is what you're going to ask the patient itself to get more detailed question. So whatever the GP writes, you should just ignore. Because you are the one who's taking more further histories. Is it a fix?
Yes, because there is a jerking. And however, there is no incontinent or tongue biting. I think so. This patient might have epilepsy with aura.
Okay, anyone?
Because there is evidence of she had emotional. The occasion mostly occur when she is in emotional situation or in a hot situation.
Okay.
This shows that she had aura first, the symptom before she had the convulsion or fit.
Emang kena betulkan kamera, susah nak tengok.
Oh, okay. Sebab pegang.
Oh, tak ada ni, tak ada head holder.
Yeah.
Okay, bantal je. Okay, so I must say this is a fix. The reason that this is a fix because he mentioned about multiple episodes. Lepas tu dia ada macam aura kan, emotional situation ataupun feeling hot. Okay. Betul. Ishman, do you agree with Aiman's thoughts? Ataupun orang yang nak bangkang Aiman?
But this is the first episode of this, right? Yang before this, yang fainted tu just faint only kan? Tak seizure kan?
Convulsion bukan trigger seizure ke?
Tak, yang
febrile convulsion.
Febrile convulsion tu at 18 months of age kan? Lepas tu dia pernah pengsan 5 kali. On 5 occasion. Pengsan je kan? It's not seizure kan?
Maybe it's because right now the presentation was because the complication of the previous seizure. Because a febrile seizure can have epilepsy complication.
Okay. Okay. So
that's why the current presentation is epilepsy.
So I would say, Ishman, you as a leader, you basically just get more information for your colleague, and then you can make a conclusion whether this is a fit or not. Okay. Anyone else want to add more things?
I think so. The fainted history tu, maybe can ask detail how she faint. Is there any evidence of jerking movement? Ask more detail about the fainted history from the mother.
Okay, my hint is fits is a fits. Convulsion is fits and convulsion is the same thing. The question now is whether the fits or convulsion is it epileptic or non-epileptic fits. Faham tak?
Faham.
So from the history, you want to know whether this is epileptic or non-epileptic. And plus, there's multiple causes of fits. It could be infection, it could be endocrine, it could be metabolic disturbance, it could be structural anomalies, it could be genetics. So those are the you need to think about causes of fits. If you guys have read about ILAE, which is International League Against Epilepsy guideline, so there's a quite simplified flow chart to suggest whether this fits is really epileptic or non-epileptic. So if you see a fit, it does not mean it is epilepsy.
Epilepsy is at least to unprovoked seizure, right? So this child, it's like that. Maybe she fainted because of the emotional situation. That is provocation.
What?
So Anis try to point out dia punya thought that this is probably not epileptic seizure. Dengar tak?
Dengar.
So that's what she mentioned there. Cakap lah Anis macam
Kau macam epilepsy. Because epilepsy is defined as unprovoked seizure, at least two. But this in this case that the child maybe because she has febrile convulsion and because of the fever, but I think it's non-epileptic. You reach mine?
Maybe juga lost um, um, because I think she might have like anemia because of she also have seen GP for heavy periods. So I thought that maybe because of the fainted because of fainted and feel clammy because of anemia. Mhm. Sebab tu dia like always anxious kot and lepas tu ada sensation of heart racing. Heart racing tu kan palpitation kan.
Mm-mm.
So ada underlying anemia.
So is that sensation of heart racing, is it quite significant? Is it significant or not in your history?
Not bad.
Sign of palpitation like anemia.
Like kalau if you got palpitation due to anemia, you will have palpitation all the time. Maknanya 24 hours constantly you will have palpitation kalau you are anemia. But normally with anemia you don't really have palpitation. You will have tachycardia, but you won't really feel the sensation because you will have the chronic changes to your physiology. And so if you anemic, your heart rate will be slightly higher, but you won't feel your heart racing your heart racing because you will have tachycardia, but you don't feel the palpitation because it's a chronic changes over time due to the anemia. So if you see like a thalassemia patient yang anemic, and they know that they develop palpitation when the HB is dropping. Tapi in this case, she has sensation of her heart racing every few weeks. Does she have anemia every few weeks? Okay, so palpitation is a very significant piece of information here. Okay, the brief episode of jerking movement, and also she regained her consciousness within a minute. There is a very important piece of information because it can tell you whether this is non-epileptic or epileptic seizures. Does the history from the aunts collapse and die at the age of 28 significant or not?
Yes. Maybe the palpitation because of the arrhythmia.
Okay. So now you're talking about more towards cardiovascular rather than apa tadi
endocrine.
Any underlying autoimmune ke?
Okay.
Because she also is a girl. Girl can also prone to autoimmune disease.
Oh, yeah. Girls agree with that statement?
Sadly.
Very sexist punya comment here. So girls prone to autoimmune condition. All right. So how are you going to approach this case?
We go by system.
Okay. All right. Go by system. Okay. Let's see how we go by system. Okay, Faiz okay, Faiz? Mana Faiz ni? I really thought you are 17 years old. Okay, so Wajah kata we go by system. So how are you going to approach this case, Wajah?
first we go by CNS. So maybe we find out what are the causes of the seizure in CNS system, such as meningitis, any infection, encephalitis, abscess, and then is there any SOL or stroke, infarction, and then cardiovascular, maybe arrhythmia such as SVT, and then endocrine, such as what Wana said before, hyperthyroidism, and then metabolic causes. We should exclude all the metabolic disturbance, and maybe patient has hypoglycemia.
So what question you want to ask for what endocrine punya ni? Endocrine kind of question. What question you will ask? Okay, so
endocrine disease.
Okay, I say no. Let's say no. She has no endocrine disease. Takkanlah korang nak tanya awak ada endocrine disease tak? It's just not apa orang kata apa? It's not a way that you ask question about that. Macam korang tanya awak ada diabetes tak? So they don't know that they have diabetes. If they come in for the first time, they don't know they have diabetes. So you need to ask question about the symptom of diabetes. So have you been drinking more than usual? Have you waking up at night to drink more? Have you been weeing to the toilet more than usual? Have you waking up at night to wee? Macam bangun every night, bangun once a night, and then bangun once a night to drink and once a night to wee. That's quite okay. But if you waking up at night 3 to 4 times to drink, 3 to 4 times to wee, and that's quite significant. So those are the questions about endocrine. But in this case, she's not, and she got no sign of polyuria, polydipsia. So what are the endocrine questions you want to ask?
Any tremor?
What's about
ask about the hyper symptom, whether there is hyperhidrosis, loss of hair, and also the menstrual cycle.
So those questions untuk patologi macam mana?
Approach for the hyperthyroid.
Hyperthyroidism. Okay, so you're talking about hyperthyroidism. Okay. So what else? What other question you want to ask about metabolic disturbance? Remember, she's 11 years old. Girl, as your colleague says, this is a girl. And girls always got problems, isn't it? Okay. So what question you want to ask about 11 years old girl? Remember when you are 11 years old, 12 years old, what would be your main things that you would think about? Puberty. Okay, puberty. Okay, what else? So when you reach puberty, what would be your things that you probably be more aware, ataupun something that you feel difference?
Period.
Okay. Period lah. Puberty tu period lah, sama lah lebih kurang. Okay.
Physical changes.
Physical changes, kan? So physical changes. So what would be your conscience at that time?
Looks.
You're talking about your looks, your appearance, isn't it? So you probably want to put some more makeups because you are now 11 years old. You probably want to control your diets because you want to look like slim. You want to be a swimmer, and so you want to lose weight if you for those yang body image punya conscience lah. So some of the child might develop anorexia nervosa, and so they might eat, and after that they will induce vomiting and vomit. So those are the things that you want to know. You also want to know whether has she been skipping her meals, her breakfast. So you want to know the diet macam mana. Adakah dia quite good diet? She may be develop hypoglycemia because she's skipping her breakfast every day, and probably not eating lunch as well. So those are the things that you want to know further as well. So does this child basically collapse ataupun having this query fix due to hypoglycemia? And so those are the questions you want to ask. So has she been developing symptom of anorexia nervosa? Has she been losing her weight? Has she been skipping diets and so on? So those are the things that you probably want to ask for the question as well. Okay, the first session of the heart racing. So this is palpitation that we call it. And you want to know this palpitation, does it always happen prior to the fits, or every time dia ada 5 fits and 5 fainting episodes? Does the palpitation happen every time before she fainted? Okay, because if the palpitation happened and then she fainted after that, so it's probably that this fit is due to cardiogenic fits. Okay, mana fitting dia because of the cardiac problems. Okay, and plus with the history of her aunt died at the age of 28, so that's quite a young age to die. And then dia kata her aunt collapsed and then died at the age of 28. So there's very suspicion that this could be cardiogenic causes. Okay. That cause the patient to collapse. Okay. Kalau somebody collapse with endocrine condition and so on, normally they collapse multiple times. So I think her aunt collapsed because of the cardiogenic punya cause rather than anything else. Okay. And then she topped her class at school. So it's just saying that she has no cognitive function punya problem, there is no intellectual disabilities, there is no developmental problem lah. That's as easy as that lah. Okay. The question now, you want to know whether this is a fix or not. What question you want to ask to differentiate between fits and not a fix?
Fits and fits.
The symptom during the fainting, like before, during, and after.
So you're talking about pre-ictal, ictal, and post-ictal. Okay. So 2 seconds. I need to. Yeah.
Okay.
Hello. Yes. Negosiasi off. Contraindication untuk apa?
Apa soalan doktor tadi? Pre-ictal apa? Nak bezakan
Fit dengan non-fit.
Fix dengan non-fix. Tapi
Fit
dia
dengan
jeki-jeki tu tak fix ke?
Ha?
Yang dia jeki.
Jeki tu fix kan?
Bukan, dia kena bezakan epileptic or non-epileptic.
Aku rasa itu
yang
aku rasa tu doktor nak.
sebab aku pelik asal fix dengan non-fit lah.
Kalau non-epileptic tu macam cardio punya tu, lepas tu dengan hyperthyroid tu.
Bukan pasal brain lah.
Kalau epileptik apa brain ke?
Kalau epileptic tu yang macam fit.
Give me 5 minutes 5 minutes ya.
Okay.
Kalau korang, can we take a break for 5 minutes?
Yes.
Okay.
Kalau epileptic tu yang tu. Yang seizure dengan febrile convulsion.
Macam mana?
Kalau dia kan kalau patient first datang dengan seizure, kena tanya dia tu cause dia epileptic ataupun non-epileptic. Kalau epileptic tu dia dua tu yang fit dengan febrile convulsion tu. Kalau kalau non-epileptic kena tanya simptom of hyperthyroid, CVS, infection CNS tu.
Metabolik jugalah.
Metabolik masuk non-epileptic.
So ni bukan ni epileptic dah kan?
Macam nak epileptic je.
Tapi sebab
Dia
apa ada jerking apa semua?
Kenapa ada je? Lepas tu dia ada febrile convulsion ni.
Maksudnya kira
History of
epileptic lah
febrile
kan?
convulsion.
Maybe sebab tahu ni yang hypoglycemic ni kan cause fit kan?
Boleh.
Tapi yang yang history of heavy menstruation tu dia nak indicate apa
Anemia.
So, apa lagi?
Hyperthyroid.
Hyper selalunya amenorrhea.
Betul-betul.
Ini heavy kan?
Heavy.
Dia contradict dengan hyperthyroid.
Bukan kot.
Aku rasa dia ni kot. Aku rasa heavy menstrual ni sebab ni kot. Dia thrombocytopenia. Hematological disorder.
Yang tanya dia rush ke tak pula? Easy bruising.
Tanya tu pula.
So apa kaitan macam easy bruising dengan seizure?
Sedihnya Mama suara kau. Hemorrhage dekat brain. Lepas tu bolehlah seizure.
Hemorrhage kat brain mesti ada macam sign symptom of increased
SOL
ICP.
apa?
Tanya lah kot. Vomiting ke benda.
Tapi dia punya history 3 weeks ago at school, fire alarm pasal dia pengsan.
Sebelum dia collapse, dia rasa macam nak
Psychology pula.
mungkin juga anxiety kan.
Psychiatry.
Tapi macam boleh jadi hyperthyroid je.
Dia nak pengsan on about 5 occasion, lepas tu mostly in emotional situation.
Itulah, aku rasa ni.
Dah dia anxious.
Sekejap, yang tu bukan masa dia 18 bulan ni.
Tu 18 bulan.
That's why dia tanya.
Tak, dia tak.
Ni anxious and palpitation ni macam mana boleh tahu umur 18 bulan?
Tapi yang dia pengsan tu 18 bulan kan? Yang dia pengsan
Yang tu yang dia pengsan
rasa febrile convulsion tak ni lain kot. Febrile convulsion tu kat 18 months.
Yang fainted tu tak tahu.
Yang
Fainted tu adalah sebelum-sebelum ni.
Faham.
Sebab tu aku cakap tadi, tanya detail lagi pasal fainted punya history. Macam ada jerking tak ke. Lepas tu
Yang tanya trigger tak masa ni?
Lepas tu yang Anis cakap provoke tu macam mana?
Itu yang aku faham epileptik dengan non-epileptik ni dia macam sebab epileptik ni non-epileptik tu dia macam ada sebab sebelum berlaku seizure tu. Macam Daya cakap hyperthyroid. Macam dia tiba-tiba rasa tu lah. Palpitation semua ni.
Rasa dia ni provoke
dia sebabkan apa?
Yang ni tak ada provoke kan? Tak ada fever. Maksud provoke and provoke tu sebab dia tak ada previous symptom. Contoh kalau provoke ni, kalau febrile kan, dia ada fever sebelum tu sama ada URTI ke apa. Tapi ni tak ada apa-apa pun. Ada aura je.
Tapi
ni epilepsi boleh tak ni? Aku rasa ni epilepsi.
Tapi doktor macam tak nak, macam bukan epilepsi ya. Sebab sama epilepsi dua unprovoked kan. Yang ni satu je.
Sebab yang ni anxiety apa semua ni.
Kalau epilepsi dia punya definition tu at least
aura dia apa? Aura dia.
Tu, anxious dengan sensation heart racing.
Orang nak cakap. Okey, Sarah.
Aura dia bukan clammy.
Aura dia macam yang clammy boleh tak?
Dia rasa macam sejuk-sejuk. Tu aura kan?
Seram sejuk. Dia ada macam simptom-simptom sebelum kau dapat penyakit tu. Macam migraine pun ada aura agak. Migraine kau muntah dulu ke apa, lepas tu dia dapat sakit kepala situ.
Aura untuk seizure ni Dr. Razana cakap boleh jadi macam kau bau benda pelik-pelik, kau nampak streak of light, kau rasa pening,
rasa macam ada benda lalu ke,
kau dengar something.
Macam nampak hantu.
Rasa macam halusinasi. Macam hantu lah.
Hantu lah. Aura.
So confirm mana epilepsy with aura.
Check WhatsApp group.
Tapi doktor macam suruh tu lagi korek lagi apa lagi delete. Sebab kita kalau nak epilepsy je macam tapi tu unprovoked.
Tu unprovoked. Tapi boleh je one unprovoked and a probability of further seizure occurring.
Oh maksudnya kena tanya after that lah macam mana? Over the
Post-ictal.
next 10 years.
Yang pre-ictal yang post-ictal
Itu kan tanya tak.
Ni pun ada post-ictal punya simptom. Dia cakap lepas within a minute of regain consciousness, dia rasa weak. Yang weak tu adalah strong
Post-ictal.
point untuk ni post-ictal punya simptom.
Tapi one unprovoked tu dia kata after 2 unprovoked seizure lah. Macam dah berlaku 2 sebelum tu.
Ini sekali je kan?
Ni sekali.
Dia tak ada demam lah ni kan?
Dia tak ada demam,
Dia tak ada
unprovoked
demam. Kita kena tanya ada demam ke tak ada.
Kena tanya.
Dia tak
kita
perasan.
tanya dulu, okey.
Ataupun ni boleh jadi the first episode of the epilepsy.
Boleh juga.
So kena tunggu lagi 10 tahun, mari mula pula tu.
Oh gitu. Atau kita biar je lagi.
Sebab kalau first seizure dia tak buat apa-apa kan. Management dia.
Tapi ni epilepsi ke seizure?
Dia patient with febrile convulsion, dia complication dia tu epilepsy. So maksudnya ni seizure tu dia epilepsi, bukan seizure.
Oh payah.
So budak yang ada febrile convulsion ada tendensi untuk ada epilepsi.
Benar.
Betul.
Yang unprovoked ni apa maksud unprovoked?
Unprovoked tu maksudnya tak ada demam. Maksudnya tak ada
demam.
Tak ada URTI, tak ada apa-apa sebelum tu.
Dia tak ada
Tiba
infection
je.
apa-apa. Lepas tu tiba-tiba dia pingsan ke, lepas tu ada jerky movement apa semua tu lah unprovoked.
Maksudnya tiba-tiba lah. Memang tak tahu sebab apa.
From the brain lah itself.
Tapi kalau
Ni doktor maksudnya ni ke? Yang apa ni yang aku tunjuk dekat grup ni, yang paroxysmal non-epileptic event. Tu kan maksudnya doktor?
Mana?
Sabar Faiz, sabar.
Oh ni.
Provoke fever, trauma, itu.
Lain ni, tak ada kaitan.
Macam sama
Tak
betul
ada,
tak? Dia
tak ada
dia sama.
pasal metabolik pun.
Dia ni
Mana?
simptom kan? Dalam grup pediatric sub 1. Dia macam
psychogenic non-epileptic seizure.
apa?
Psychogenic non-epileptic seizure.
Dia macam dia simptom yang mimik seizure. Sebab tu dia panggil non-epileptic.
Kalau provocation tu demam je ke?
Dia actually
Tahu ada kalau sebelum ni waktu CW aku fikir demam je.
ni ada trauma. Electrolyte.
Trauma kita tak cakap lagi.
Boleh lah metabolik apa semua.
Doktor sekarang tengah korek check up lagi. DDX.
Atau nak benda lain je.
Tak ada DDS ke?
Tak ada DDX lagi. Kan kita dah bagi epilepsi. Lepas tu hyperthyroid. Tu je.
Ni meningitis boleh tak?
Yang tu,
Kita
yang
kena-
CVS. Meningitis boleh tak?
Metabolik pun kita dah bagi tahu kan.
Metabolik dah.
Dah.
Lepas tu kan
Hypo dengan hyper.
metabolik hypokalsemia tu macam mana kita nak bagi tahu dia punya simptom
Yang tu rasanya by
investigation
je.
Ada soalan boleh tanya. Kurang minum susu ke?
Vitamin D deficiency ya.
Aku kurang minum susu.
Muscle
Jadi
pain ke?
Makin tinggi. Makin tinggi. Maman kau tu.
apa? Aku tak diagnose.
Saya maman.
Macam dah nasi ada kat
Kalau
ni.
hypokalsemia dia still akan bagi simptom. Ada simptom juga kan?
Ya.
Arrhythmia boleh.
Kalsium.
Boleh tak sebab dia ada palpitation.
Sekejap lah Najla, aku tak terfikir pun.
Aku tak fikir kat.
Aku drug pun boleh kan?
Tak boleh tadi sebab aku tak nak kata ni tapi tak tahu.
Boleh lah. Ingat.
Drug boleh jadi
By the way,
seizure ke?
apa? Boleh?
Takut dia ada heavy menstrual kan? Dia ada heavy menstrual lepas tu doktor
Dalam
bagi drug yang
NSAID,
untuk
use
macam
NSAID.
blood clot ke lepas tu mati.
Sekejap, ada banyak lah.
Mata drug lah ada boleh kan?
Kalau genetic cause apa contoh dia?
Genetik.
Inborn error of metabolism kot.
Wow.
Metabolic diseases.
Tu dalam bukunya ada tu GEFS apa tu?
GFS tu lah.
Dia kata autosomal dominant.
Okay, jangan sebut. Nanti doktor tanya. Jangan pandai-pandai sebut.
Betul kan? Autoimmune biasa dekat female kan?
Taklah SLE je kan?
Kebanyakan.
Kebanyakannya female.
Kebanyakannya female. Betul-betul.
Apa yang seksis
Mama ni
lah?
resis lah.
Doktor tak ada
Macam mana doktor tahu isu-isu sekarang? Perempuan kan kan banyak masalah.
Nak cakap kan. Video ni rekod tau.
Video ni dong. Masuk kat YouTube.
Tak ada tu? Tak ada kad daya pun?
Ada tu button
Tapi dia
record. Doktor record.
Recording ni setiap masa ada tulis recording.
Tak,
So maknanya tak recording.
host yang record.
Sudah.
Host maksudnya kat dayah ada host.
Doktor kan. Doktor guna account tu kan? Tak kan?
Rasa macam tak. Lagi ke?
Hai, Assalamualaikum. Balik lu.
Senyap.
Semua mute mic.
Tak nak.
Tak nak cakap.
Nak kejut sore ke?
Weh, masa doktor senyap. Masa doktor semua
Masa doktor mama seorang je.
Okay, tinggal tu.
Weh, masa doktor semua macam tak nak jawab
Cakap
apa.
macam tak nak cakap.
Aku sadar.
Soalan duduk di angkasa sekarang.
Ya, berapa bulan?
Macam mana kau buat macam doktor buat?
Doktor kat
Virtual
pulau.
background.
Nak tekan mana?
Nak tekan mana?
Google.
Video. Ada cari virtual background.
Allah, internet dia.
Mana?
Video virtual
Google.
background. Google.
Kat video tu, ambil anak panah tu, lepas tu cari curet. Alah, perlu ke?
Anak panah.
Oh, dekat stop video tu.
Mana?
Anak panah kecil. Anak panah kecil naik ke atas.
Oh.
Mana ni?
Kat stop video anak panah kecil.
Okay.
Betul okay.
Tu virtual background.
Semua nak buat ni.
Doktor buat macam biasa kita try.
Wah. Tak nampak muka aku lah.
Nampak mari.
Apa ni? Pintu tak tu pun.
Hudu dah. Faiz on. Ya, tak cantik lah, tak jadi. Yang doktor punya cantik, boleh nampak betul-betul.
Kan?
Boleh browse dari picture yang ada dalam laptop kau.
Oh ya.
Tu kosong lah kan.
Percaya.
Oh gitu.
Tak okay, apa boleh tak?
Tak?
Nampak mari. Ada mari
Siap gerak-gerak lagi kau punya fokus.
Daya. Daya cakap yang hyperthyroid boleh heavy period dengan tak period tu macam mana? Dalam group tu.
Sebelum ni dah buat tu apa? PBL. Lepas tu dua-dua can cause hyperthyroid macam irregular menses. So maksudnya tak spesifik yang mana satu yang boleh menyebabkan tak ada, yang mana satu yang menyebabkan terlebih. Tapi tadi Wajib cakap hyperthyroid tu kan? Hyperthyroid A kan?
Biasa hyperthyroid amenorrhea.
Betul. Raja cakap, bukan Wajib cakap.
Raja cakap.
Gaduh.
Songkong je.
Ya, dia terbalik pula ada phone.
Tapi time IM kan ingat tak patient dalam bilik tu? Dia kan hyperthyroid. So tapi dia heavy menstruation. So macam tak rigid sangat. Patient dalam bilik.
Mana.
Dia hyper dengan thrombocytose.
Macam cari wallpaper.
Dah ya.
Pasal makcik mati
Kenapa
awal.
tak cantik?
Cardio vascular.
Saya arrhythmia tu lah.
Oh, maybe.
Mungkin.
Sedapnya orang tu makan.
Dah ya kena cari. Dah kena pakai tudung warna lain.
Ya.
Sebab dia effect colour. Dia detect colour.
Ni tudung warna coklat eh.
Yelah tudung sama macam background gitu warna.
Yalah.
Oh.
Aduh.
Tukar tudung.
Ya, aku nak ambil gambar. Boleh hilang tak?
Sabar.
Makan apa?
Tak payah sebut. Hilang.
Makan biskut je.
Dah makan dah kau?
Belum.
Tak makan lagi weh.
Ni baru makan.
Cafe buka ke tak Najla?
FFZ
kopi.
dah jauh stay aku.
Najla bukan suka FZ.
Suka.
Naik motor selalu.
Kau bayangkan. Aku duduk dengan orang ni. Tak suka makan.
Najla siapa yang ada kat Mahala sekarang?
Ni record ni aku takut.
Tak payahlah guna. Tak cantik lah aku.
Tukar tudung.
Alah
Kau dapat gambar oh.
Pakai semaya.
Sama nak main dengan kau ni.
Cute sikit.
Tak ada gambar pun.
Ada. So Haida duduk disco ke?
Tu apa je clubbing.
Macam
Mama selalu dia macam pose macam takut macam Pais oi. Bunga terus tak ada nama muka. Aju kau guna phone ke?
Tak guna laptop je. Tak
Kenapa tak guna laptop?
Laptop nak chat dekat WhatsApp apa semua. Check
Eh
information.
pelik.
Balik rasanya.
Laptop mahal.
Handphone dia pun mahal.
20.
Kena beli stand. Macam
Apa
Dr.
ni?
Kata.
Seminar minggu depan last
Minggu ni.
Minggu ni ya?
Betul-betul dah.
Mana ada konten doktor?
Tapi dah balik. Dia kata tunggu jadual baru. Maybe nak ubah jadual.
Aduh.
Tak nak.
Next week ONG kan?
Kena kabut dia. Mau nak relax.
Next week ONG? Serius lah. Kita kan
Patutlah
delay
kita
1
cari
minggu hari
relax
tu.
je.
Tapi mana boleh kita delay orang lain semua dah next week. Lepas tu baru kita
Itulah
delay.
masalah dia.
Mana
Kita
boleh.
kan
Kita
masa
ni
orang dah
record
start kelas
ke
kita.
tak?
Ha?
Record je.
Tak keselamatan semua senyap.
Ya boleh keluar.
Aduh, gaduh.
Alright, sorry guys. For disruption. Okay, so where are we? I can't remember now. Where are we now?
Epilepsy dan epilepsy.
A different.
Kardiogenik.
Okay, fine. So I think we're talking about pre-ictal, ictal and post-ictal punya phase of epilepsy. And so in the history, you always want to make sure that if this is an epileptic fit, you want to know whether the events fits all those three phases of seizure. So dia ada apa? Pre-ictal. Pre-ictal ni selalunya aura, some sort of triggers, not triggers, something that probably induce the seizure. For example, maybe alcohol or drugs or lethargy, lack of sleep. Okay, so those are the pre-ictal punya history. The ictal is what actually happened. So kalau dia collapse tu macam mana? Was she watching TVs? Was she standing up? Was she playing? Was she eating and so on? Then she collapsed. Has she got any jerking movement? And jerking movement, you want to know, is it the whole body jerking? Was it just one-sided jerking? And then generalized to the whole body? Or whether it's just partial seizures. So those are the ictal states. and then you got the post-ictal, which is normally drowsiness, sleeping, and so on. Okay, and normally the post-ictal tend to happen a long time, maybe about 20 minutes, up to 2 to 3 hours. If they gain consciousness almost immediately after the fits happen, then most likely it's not really an epileptic fit. It's probably just something else. It could be cardiogenic, it could be vasovagal, it could be anything lah, and not epileptic. So that's why when talking about fits, it is a fit. However, is it epileptic or non-epileptic fit? Okay. So those are the most important thing. With the epilepsy, and obviously, if you look at the ILAE guideline, you've got the level 1, which is the unknown onset. The second line is the type of seizure. Is it GTC? Is it atonic seizures? Is it absent seizures? Is it clonic seizures? Banyak lagi type of seizures. And then the level 3, which is the syndromic epilepsy ataupun epilepsy syndrome. And at all levels, you need to know what is the causes of that. So, endocrine, infection, genetics, metabolic, and so on. Okay. So from the history, so it is Cindy is 11 years old. So you want she has multiple episodes of collapse. She had febrile convulsion when she was 18 months old. And then she always feeling that she got palpitation every few weeks. And there is a family history which is her aunties died at the age of 28, which is quite a sudden death, or also kita panggil mati in a younger age. And that's also emotional situation. The most important thing about this fit, she said that 3 weeks ago she was at school, and then there was a fire alarm went off unexpectedly, and she felt faint and so clammy. The fainting and clammy. The clammy means that it's probably reduced blood pressure, reduced blood supply to the peripheries. So that's why it caused. This is other information that probably suggestive of cardiogenic fits. Okay, not really epileptic fits. Faham tak?
Faham.
Okay. And obviously, as I mentioned before, you want to know the diet histories. You want to know her diet and so on. So it's very important to make sure that all those information been asked. Okay, and then now I'm giving you the examination punya findings, which is basically not much to find there. So the height there is on the 91st centile, the weight there 53 kilogram, which is 50th centile. So it's not really anything significant in that particular physical findings. Okay, so let's go back. Siapa yang present dia? Ishman kan? Let's go back to your differential diagnosis. So what will be your differential? So you're talking about possible seizures, okay? But what is the causes of this seizure?
Maybe because of cardiogenic, I think.
Okay, so you're talking about cardiogenic, okay? Any other causes?
Or maybe hyperthyroid.
Okay, so you're talking about hyperthyroid. So you also want to ask further question about hyperthyroid symptom lah. Okay. The other thing is when people say about emotionals, okay, sometimes you can get we call it panic attack ataupun anxiety kan. Okay. So sometimes panic attack also can make them collapse as well ataupun having seizure as well. So panic attack. So that's why you mentioned that if she's emotionally disturbed ataupun mostly emotional situation. So sometimes she might have element of panic attack that cause her to collapse. The second thing is I would like to mention about seizures is sometimes you can have, we call it pseudo seizures. Maknanya it looks like a fit but it's not a fit. Pseudo seizure ni the difference between pseudo seizure dengan seizure is seizure tend to happen anytime. Maknanya it can happen anytime, during the daytime, the nighttime, sleeping, awake, and so on. Pseudo-seizure, by definition, is basically a psychological condition. And if it's normally, if it's psychological condition, it always tend to come with people. For example, pseudo-seizure don't happen alone. Mana kalau dia duduk seorang-seorang dalam bilik, dia tak kena ada seizure. Okay, pseudo-seizure always tend to have an audience. Dia akan berlaku bila ada orang dekat dengan dia. Dia tak akan berlaku seorang-seorang. Itulah pseudo-seizure. The second thing about pseudo-seizure is, if you got a seizure, you will never have an injury. Yang mana kalau orang yang ada proper seizure, sawan betul-betul, when they collapse with, mana dia collapse, dia jatuh, dia akan ada, mungkin dia bang dia head ke, ataupun ada luka-luka sikit ke, abrasion and so on. Pseudo-seizure, dia kan, mana kalau dia ada sawan, dia boleh control dia jatuh macam mana. So most of them who has pseudo-seizure, when you ask them, does the seizure cause them or inflict them any injury? Head injury ke, banging to the floor ke, to the table ke, ada abrasion and so on. So normally pseudo-seizure does not have any injury. Kalau proper seizure, they will have injuries. Faham tak?
Faham.
Okay, because pseudo-seizure is macam pseudo-seizure is something that you make up. Itu masuk pseudo-seizure. Kalau if this child is like 2 years old or 3 years old, sometimes you can have, we call it reflex anoxic seizures, where the causes of the seizure is due to some sort of unwanted stimulus ataupun painful stimulus. For example, budak ni kena ketuk ke ataupun dia jatuh ke, and then they cry and then they have a seizures. So it is a stimulus that cause that. It's almost the same as breath holding attack. So dia nangis sampai dia biru, dia tahan nafas, and then they will have the jerking movement. So it's not a seizure, it's just orang kata non-epileptic seizures. It's a seizure, but it's not epileptic seizures. Okay, faham? Okay, now, so causes, Ishmael says the causes of the seizure, it could be cholegenic, it could be the endocrine causes kan. Okay, and I would like to add more in this case, it could be also the metabolic causes, for example, hypoglycemia, but obviously you need to ask further question regarding the diet lah, kalau dia skipping the breakfast ke, skipping the lunch and so on. You also want to know the pattern, habits of eating as well. So does she eat and also she vomits or induce vomiting, and also you want to know what dia punya weight punya pattern. Has she been losing weight for the past few months ke, for the past few weeks ke? And sometimes puberty, because of the changes to the endocrine to the hormone, and sometimes it also can cause induce seizure as well. Okay. Okay. Right. So now, what investigation you want to do?
I can do renal profile.
So let's see. What investigation that will help you reach the diagnosis?
EEG.
So you want to do the target function test, which is fine.
ECG.
EEG and ECG.
Use
Random blood sugar.
Okay, random blood sugar is good because random blood sugar will tell you whether the child got hypoglycemia at the time of the collapse. So you're talking about so the first thing everybody who collapse, the first thing you want to do is you want to do blood sugar, okay? Because you can fix the blood sugar very quickly, okay? Obviously the EEG and ECG will take some time, okay? But I will assure you that the EEG is not going to be helpful in this case, okay? The most helpful thing is in this case is the ECG, okay? Because the ECG will tell you whether this child has arrhythmia or not. Okay, so I would put you to my slides. Okay, can you see my slide?
Yes.
Okay, so causes of a seizure ataupun fits, it could be epileptic seizure. However, you need to get more question from the histories, like aura, which is pre-ictal, is there any incontinence, is there any tongue biting, is there any family history. So in this case, there is not really any symptom or history that's suggestive of epileptic seizure. The question about cardiac arrhythmia, cardiogenic fits, which probably more relevant to this case, is the history of palpitation, also history of sudden collapse. Also, however, we've not asked about exercise related. So everything about cardiogenic is asking about, has the seizure happened during, tend to be induced when you exercise. Okay. If you got syncope ataupun macam vasovagal syncope, so sometimes it preceded with the stimulus, which is in this case, she mentioned about the school alarm bell started, and then because of this, she felt funny, and sometimes with the vasovagal syncope, you have dizziness and also nausea. The other thing you want to get more from the history is how long she will take for her to recover. So in this case, she gained consciousness within a minute, which is a very suggestive of vasovagal syncope. Panic attack, so you want to ask about hyperventilation atau memang dia ada history of anxiety, and then with the panic attack, you can have this paresthesia feeling around the arms, and sometimes you can have the spasm of the feet. Breath holding attack tend to happen in toddlers, same as a reflex anoxic seizure tend to happen in very young age. Normally, I would say less than 4 years old. Seizure seizures, as I mentioned before, is mainly psychological conditions. It tend to happen with audience. It never happen on its own. And other causes is hypoglycemia. So in terms of tests you want to do blood sugar first at the time of the event, and then for the cardiogenic you do the ECG, and then if this two does not really explain the causes, then you can end up doing the EEG on this child. For me, it could still be pseudo seizure as well in this case. Okay, so in this case, the history is suggestive of vasovagal syncope. It could also be a cardiogenic fit, and it could also be a panic attack. However, the history really not really suggestive of epileptic seizure. Most likely, the reason for that is because the convulsion is so brief. Because it's so brief, it probably tend to be due to hyperperfusion of the brain because of the hypotension, and then you can have this anoxic seizure, in a way terminated by being supine after collapsing. The most important investigation in this case is ECG. EEG probably not really going to do much in this case, and obviously for all seizures you always do glucose, electrolytes, calcium, magnesium, but most of the time they are all quite normal apart from glucose if we are talking about hypoglycemia. Okay, now I'm going to show you the ECG for this child, and then I want you to tell me what does it shows. Hmm?
QRS.
Is it prolonged QRS? Is it?
QT.
QT what?
Long QT.
Prolonged QT.
Prolonged QT. So can you calculate the corrected QT for me? So can somebody calculate the QT, the QTC kita panggil, corrected QT intervals? So first of all, can somebody calculate the heart rate?
Okay.
So what's the heart rate? Faiz, boleh kira heart rate dia?
So
100.
20.
12 kan?
12? Apa yang 12?
15.
15.
15. The heart rate.
Yeah. The heart rate 15? Cannot be 15.
70.
So what is your formula for heart rate?
300 divided by
Divided by?
boxes between two large boxes.
QRS.
Okay, so what's the boxes here? How many boxes?
20.
4.
4 ke 19 ni? Oh, tak ingat ini, korang dah tak ingat ini.
20.
So divided by big boxes, bukannya small boxes, big boxes. So big boxes here, big boxes here ada big boxes tu adalah 5 to 5, mana 5 times 5 is a big boxes. So I don't know whether you can see my cursor.
Yes.
So 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So this is all big boxes. Okay. So there is one big boxes. Okay. So if you want to calculate the heart rate, you want to do 300 divided by big boxes. So how many big boxes here?
4.
4. Okay. 300 divided by 4 is going to be
75.
75. Pandai. So great. Okay. Now show me. So give me the formula to calculate the QTC, the corrected QT intervals. What is the formula for that? Ingat tak? Ingat? Kau ingat tak? Tak ingat?
Kira box je.
Kira
Small
box ke small box ni kan?
Okay.
Small box lah.
From
One
P,
small box is
from
0.02.
Q.
0.02.
0.02 second. One small box.
Okay, 0.0,
0.04.
0.04. One small box is 0.04. Okay, because one big boxes is 0.2. So 0.2 is one big boxes. So small boxes will be 0.04 small boxes. Okay, so what is the formula for QTC, corrected QT intervals? The formula for that?
It's normal. 9 to 11 small box.
No, the formula dia untuk calculate QT intervals, QT corrected intervals. We call it QTC. Okay, so Ismail ni siapa Ismail ni? Ismail, Ismail ke?
Isha.
So she's given you the formula to calculate corrected QT intervals. So the QT divided by the square root of RR interval. So somebody want to do the calculation? So let's do the QT punya intervals first. Okay, so the QT, so somebody can see my cursor kan? So let's say this is Q. This is Q, and then the T N here kan? So Q, R, S, and then you got the T wave. the T wave and there. Okay, so you want to calculate you want to count the small boxes. So 1,
Oh.
12.
Okay, 12. Okay, so 12, right? So 12 times 0.
0.04.
0.04. So it's going to give you 0.48. Sorry, 0. So apa?
For 0.
Times 12, right? So 0.04 times 12 is going to be 0.48. Okay,
0.48.
that's for QT. Now you're going to calculate the R to R intervals. So from R there to R there, how many small boxes?
20.
20. Yeah. So 20 times 0.04 is going to be 0.
0.8.
Okay, 0.8.
0.8.
Okay, so from 0.8, you want to do the square root of the RR. So how much you have? What is the answer for square roots?
0.48 divided by square root of 0.8.
So, tapi the RR tu you need to get the value for the square roots of RR. So you need to do the square root of 0.8 first. Barulah buat calculation for 0.48 divided by the square root of RR.
Mana calculator?
Budak medik congak aja square root ni. Boleh Faiz?
Tak, apa tadi dia punya formula?
Dekat kat chat box.
Apa? Faiz senyap ya Faiz.
.54.
0.54.
Okay, so you got 0.54. Boleh, semua orang dapat 0.54. Faiz tak datang lah.
Cari kalkulator.
Ya tu Faiz dengan kalkulator. Lama je kalkulator. Kalkulator kat iPhone je. Okay, so 0.54 dia punya we call it QTC, which is corrected QT intervals. Okay, so what is the normal range of QTC?
Normal range.
You guys have done internal medicine kan?
Dah.
So do you guys remember what is the normal range of QTC? Normal range for QTE, corrected QT intervals. Tak ingat
0.8
Normal QTC.
Siapa cakap dia?
Najla. Is it 0.38 to 0.42?
Something like that. So in pediatric it's slightly longer. We put it 0.4 atau 0.48 ataupun 0.5 lah. Kalau paling panjang pun paling prolong pun 0.5. That's the high border. Okay, so more than that 0.5, more than 0.5, in this case 0.54, then you probably consider this as we call it prolonged QT syndrome. Okay, so that's why it is important to calculate the QTC, not just checking the QT interval here. You need to do the QTC, okay? Because the prolonged QT intervals is depend on the QTC. Okay, so this is the result of the ECG. So the ECG shows the prolonged corrected QT intervals, making the diagnosis of long QT syndromes. Okay, so long QT syndrome is a case is arrhythmia punya problems. Sometimes it can be induced by loud noise, could be induced by sensation, emotional, and so on. Okay, so this patient will need cardiology referrals. They might give medication, they might give cardio defib depending on the requirement lah. So this is the way that you measure the QT. So normally we use the formula yang Isha bagi. Sometimes you can use other way, which is a QT divided by RN. So sorry, it's the same. It's the same formula that Isha bagi. Cuma kat sini dia macam tak keluar properly dia punya square root. Okay, so normal QTC in pediatric we put it less than 0.45. Some cardiologists will say it's up to 0.5, but in this case it's about 0.42. Sorry, 0.5 to 0.54, which is not too, which is a prolonged case. Okay, if you read further about prolonged QTC syndrome, there is about, I think, more than 10 QTC syndrome. They're the type 1 up till type something, so many of them. But it doesn't matter. As long as this is a prolonged QT syndromes, you will need this patient to be referred to the cardiology for further management. Okay, so take home message from this case, the commonest cause of fainting in teenagers especially is a vasovagal, but you also need to consider other causes as well, cardiac causes, endocrine causes, hypoglycemia. You need to ask further question about the diet. You need to ask question about puberties. You also need to ask question about possible psychological conditions, like anxieties, depression, and so on. And always do an ECG and also blood sugar if for any collapse patient coming to ED, because these two will tell you almost immediately whether this patient will have hypoglycemia or whether they have heart conditions. The EEG is not a tool for epilepsy, so you cannot diagnose seizure or epilepsy with EEG. EEG is just a supporting diagnosis, a supporting tools, but it is not a gold standard to diagnose epilepsy or seizure. The seizure is a clinical diagnosis. You diagnose seizure or epilepsy from the history and also examination. If the parents or the child has brought you a video footage of the events, then you can assess the events, whether it's a seizure or not a seizure. Okay, so you don't need an EEG to diagnose an epilepsy. But obviously, you will need an EEG to diagnose epileptic syndrome anyway. Okay, but to diagnose epilepsy, you don't need the EEG. Okay, any question? Ishman, any question?
So how about her aunt yang died early?
Yeah, so it could be that the prolonged QTC syndrome, mana mungkin auntie dia has a cardiac condition, so that's why she probably collapsed because of some sort of arrhythmia, and then because of that she probably go into the cardiac arrest and then die at the age of 28. So it could be that, even though makcik ni quite far from the family tree, but it's quite significant, especially in prolonged QT syndrome. There is a autosomal recessive genetic mutation in this particular condition. So it could be related that she probably also carrying the same genetics as her auntie. Saya tarik tu. Besok sehal minum teh tarik sama-sama. Tak share.
Kosong je, Dok.
Kosong. Okay. Any other question? Okay, Faiz. Jumpa calculator dah?
Faiz.
Jumpa dah.
Faiz tak ada. Ni. Ada.
Alright, guys. Any other questions? So basically, we had a case of query seizure, query cardiogenic. So you can put this as possible
diagnosis.
Neuro plus cardiology punya case lah. And then the previous case is an infectious disease case. So there's two cases that we discussed here. But obviously, your further questioning of HOPI will depend on your list of differential diagnosis. So the question that you ask parents, you will ask parents is depending on your differential diagnosis. So the longer your differential diagnosis, the more question you will ask. But obviously, for me, I'm quite happy for you to have like 5 differential diagnosis in a case. Some lecturer will say you should have 10 differential diagnosis, but no one is wrong. But I would say to you guys, think about commonest thing first. The commonest things are common, so think about common things, not the rare things. Okay, and obviously the prolonged QT syndrome is not common, but if you have somebody who mana kalau ada family history yang die quite young, mana dia mati bukan sebab accident lah, dia mati sebab mana sudden death kan. Then you need to think about cardio. Okay. Bagaimana?
Okay.
Ya, hari ni kita banyak sikit discussion argument tu, itu biasalah. Dengan orang perempuan biasalah kita argue. It's the common things. Okay. Fine.
Okay.
The rest of you got any question, Najla? Any question? No. No.
Febrile convulsion tak ada significant lah yang dia dapat waktu kecil tu.
It's not significant.
Oh.
It's not significant. Okay, it's not significant.
QT tu sebab symptom dia palpitation je lah, heart racing.
So yeah, well, the symptom could be just collapse.
Oh.
There is palpitation, maybe. So you probably don't know. Or sometimes they might have chest pain.
Chest pain.
So anything that could be cardiogenic symptom kan, chest pain ke, blurry vision ke, apa ataupun headache ke, dizziness ke, nausea ke, maybe sometimes you have numbness of the fingers. So it also could be a symptom or sign of cardiac causes kan. So anything that suggestive of cardiac causes, you need to think about doing the ECG and doing the cardiac assessment. Okay. And remember that febrile convulsion, even though it's there in the history, febrile convulsion is a self-limiting condition. So it shouldn't happen after 6 years of age. Kalau dia still ada lagi febrile convulsion after this age of 6, then you shouldn't call it febrile convulsion. You should call it something else. It could be generalized epilepsy of fever syndrome plus. I don't know whether you know this. We call it GEFS plus, or bukan PH plus, GEFS plus ataupun FS plus. GEFS plus. So Aiman dah Google. So GEF plus.
Genetic epilepsy with febrile seizure plus.
I'm not making up the plus now. It's not a hashtag plus. It's a plus. GEF plus. Okay.
Yeah.
So it's an entity that we know tend to happen with the fever, and the age of its happen. Mana dia have beyond the age of 6 years old.
I see.
Normally, you will have a family history with the same condition as well. So we call it GEF plus. So this is not febrile convulsion. This is a GEF plus febrile convulsion. Okay. So, but you know, itu extra information lah. You don't need to know. I'm not going to ask you this question masa exam pun. I don't think that most of the lecturers know about GEF plus anyway. If you tell them it could be GEF plus, I think they will Google themselves as well.
I see.
Okay. Anything else? So Madia, you want any question? Ada Suhaila? Suhaila boleh buat IT sikit esok. Okay, Afifah? Ishmael, okay? Anish? Okay, apa lagi? Hidayah? Baiz ke Baiz? Pakai ni je, pakai phone je, klik ni. The rest of them wajah tak hilang lah? Wajah tak ada lah.
Okay, Doktor.
Isyak part of the group bukan kan?
Group lain.
Apa lagi? Usna bukan tak?
Group lain.
Isyak pun group lain. Okay, fine. Alright, so thank you very much. So I will have another session this afternoon kedua dengan other groups. But obviously, I will have another session with you tomorrow afternoon.
Yeah.
Okay, so that's fine. All right. So if no question, then we're going to adjourn the session with Tadbir Farah Sawalas. Okay, thank you very much.
Okay, thank you,
Thank you,
Doktor.
Doktor.
Thank you.
Assalamualaikum, Doktor.
Assalamualaikum. See you tomorrow.
InsyaAllah.